Welcome delegates and faculty for this international webinar series number 4 in gastroenterology. I am Dr. T.S. Chandrasekhar, your ACG Governor, American College of Gastroenterology Governor, India region. I bring warm greetings on behalf of ACG as the webinar subcommittee member and also from World Gastroenterology Organization as a member, scientific committee, and also from Tamil Nadu Dr. MGR Medical University and my institution, Medindia Hospital and Academy. First three webinars, we saw the participation of over 19,000 delegates from all over the world. Who will not be inspired to go for the next series? That is the motivation to go for the next series. Every month we do this webinar. And we gave the tag as name the topic, the world experts are here. I'm privileged that being the governor of the ACG, I could get all the president and the office bearers of ACG and the top class experts from India and neighboring countries also, and goes with that news, that new Endo-GE webinar series. And the first of the series was inaugurated by none other than Professor Dr. Jonathan Layton, and the president of ACG was awarded Master of ACG this time. And the icing on the cake was the third webinar series. We had the participation of the Nobel Prize winner, Nobel laureate, Professor Dr. Barry Marshall. He discussed on how he discovered Helicobacter pylori. What was his journey was very important. And we had over 9,000 delegates from all over the world. This webinar is possible with the coordination and the cooperation and a lot of groundwork being done by my colleague Gokul, Satya, Raja, and Prasad and Trinyana Samta. And now this series has got 12 webinars from April 25 to March 26. The good thing about it, we have already lined up all the lectures for a year and we got a faculty also. I think Ram Krishna will remember that he was called almost 6 months before about this webinar, and I'm very glad that he could remember and come back and see the kind of a national faculty we have and the international faculty. You name anyone in the field, their original workers, we have them on the national and international faculty. And equally, the eminent people have been moderating and chairing and being the panelist also. This is why the webinars have been become very successful. And what we did this year, we started with the type 2 diabetes and diabetes GI tract, hypertension, both systemic and portal hypertension, dyslipidemia management and fat and liver, pharmacotherapy of obesity and endoscopy, surgical management of obesity, doctor and law, doctor and ethics. Now doctor and research grant. Now we are into doctor and finance and doctor and entrepreneurship. Now we are into two parts of first part of research methodology and next also research methodology. Then we'll have a master health checkup in gastroenterology, pre-cancerous lesions in gastroenterology. And please don't forget our due in the February 2021-22, and it is not 13, 14, 15. Please change the live demo workshop on digestive endoscopy. And the last but not least, the debate on endoscopy and surgical management in gray areas in gastroenterology. This workshop now just a poster to remind you, all of you join us, and you all will be invited as the faculty here. And webinars in gastroenterology. Video. Research methodology we have. Video. Okay, nobody. And this is research methodology, choosing the research question and choosing the thing. Now, my pleasant job to introduce the faculty. So, this is very important. Why our the webinar is successful because of the faculty we have. Ramki is a dear friend and the same time very eminent gastroenterologist, and you tell any cause for the academy session, he is there. He is the director of Institute of Gastroenterology, Sims Hospital, Chennai, past president, Indian Society of Gastroenterology, editor-in-chief of the Indian Journal of GI, Gastroenterology, Stanford University, and they recognize him as among the top two% scientists from India globally. Areas of interest, you know that IBD and small intestine, and is a good therapeutic endoscopist too, honored with the various awards and his publication H index. And is all he will tell about what H index and citation. And very eminent gastroenterologist, usually, who has been the editor of Indian Society of Gastroenterology. Again, past president of Indian Society of Gastroenterology is none other than Dr. Philip Abraham. He'll be joining us anytime. He's a consultant gastroenterologist from Mumbai Hinduja Hospital. He has been the professor head Department of Gastroenterology, KM Hospital, Mumbai, and his areas of interest luminal GI and disorder. He has got lifetime achievement award from the Indian Society of Gastroenterology. And Saurabh Datta, another friend of mine, he is equally eminent research methodologist and research worker, and he has got 5,200 citations. He is a professor of neonatology in Advanced Pediatric Center, PGM, Chandigarh, core faculty, postdoctoral fellowship in high risk pregnancy and perinatology, adjunct professor, Department of Pediatrics. Primary research in neonatal sepsis, probiotics, which is close to our heart also, gastroenterologist, retinopathy of prematurity, recipient of various awards for his outstanding service in newborn health care, and several papers to his credit. And we have equally eminent person, Dr. Sobana Bhatia is a professor of gastroenterology in the Critical Asia Multi-Speciality Hospital, a research center, Mumbai, and professor head Department of Gastroenterology. Again, he was from KM Hospital. She also been the KM Hospital. Special focus. You name Dr. Sobana Bhatia, motility and functional disease. And she did have a great this time in endoscopy too, and she got an excellence award from the National Board of Examination and several publications to her credit. Three young people. Why I selected young people for the research methodology? They will carry the information to the rest of the next generation. Dr. Grace Kumar from Professor of Gastroenterology, Shiksha O. Then University Bhubaneswar, Dr. Devendra Singh, Senior Consultant Gastroenterology, Apollo Hospital, Bilaspur. Raju, another young man who is also creating interest himself in the research methodology, consultant gastroenterologist, gastronaut clinic, Mumbai. Now, with this, I just want to tell you that several of our ambassadors, what I have done it, each one representing, each eminent gastroenterology representing the each state of our country. They work as ambassadors from Madhya Pradesh, Pravir Roy, Chaubal, Pravir Roy. We have now Praveen Kumar from Kerala, Arvind Gubbi from Karnataka, and Mahapatra from West Bengal, Nirmal Jeet from Punjab, Rajiv from Maharashtra, Venkat Iyer from Gujarat, so many. And international ambassadors also equally we have that. They spread the message of this webinar. That's why it is very successful. And this is our 37th webinar. I'm glad to inform you here American College of Gastroenterology recognized our webinar and it has been endorsed, and they presented me with the Best Governor Service Award. So in humility, I just want to tell you last week I was in Phoenix, USA to receive the award. With this, I invite Dr. Somana Bhatia to do the needful, to invite Dr. Ramakrishna, who has been and to present how important the research to introduce the topic. Then I will invite she will invite the Ramakrishna and do the needful. Okay.
Good evening, everyone, and welcome to this very important session on research methodology. So, why do we do research? Is to find out what are the questions that we need to answer, and that is how science progresses everywhere in the world. However, before you start doing any kind of research, the first question that comes to mind is what should we research on? Unless you have a good question, the answer is difficult. If you have a confused question, an inappropriate question, the answer that you get from the research is going to be equally confused and equally inappropriate. So, the first step of understanding research is to identify a good question. And I invite a good colleague, a good friend, Dr. Ramakrishna, to give this talk on how to choose a research question. Rama, over to you.
Thank you, Shobna. So, if I may share my presentation.
Please go to the slideshow and
My mouse is a bit
yeah,
slow.
yeah, right, right. Now you're through.
All right. Thank you. Thank you. And I thank Dr. Chandrasekhar for asking me to speak on this topic. It's a pleasure to be with the ACG webinars. You're doing a great job, TSC.
Thank
Thank
you.
you, Shobana, for the for introducing. So I think without ado,
Slides not seen, Rama.
no, it'll change. It'll change. Are they changing now? No?
Yeah, not seen yet.
Oops. Now?
No, screen is blank, Rama.
Oh, screen is blank. All right.
Yes.
Now what do I do here?
Ah, yeah, yeah, we
That's
jump.
it.
Okay.
Yeah, better.
No,
Yes.
no, 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 no.
We
Now
still
I'm getting the but you're not getting the show here, right? The
the
slide.
slideshow.
Slides. Okay, okay.
Is that okay?
No, no, Rama. What we are seeing is presenter notes. We need
Now?
to see only the slide.
Now?
No, now
Now
it's
black.
blank.
Oops.
Stop sharing and go back again. Yeah, this is fantastic. Go to the previous slide, your first slide. So you are searching for the question now. Very good. You got the point now. Okay.
Okay. So first let's ask what is research. I think the term research throws off a lot of people. So when you talk to a lot of people that say, okay, let's say that we can do some research, they want to know, oh, this is so obscure. What are we going to do with this? So firstly, what is research? So when you gather data, when you gather information, when you gather facts, for whatever reason, to advance knowledge, you may want to generate a process, you might want to generate a product, you may just want to improve treatment. So when you gather the data and information, that is research. So all these the browsers that we have today, they actually help you with a lot of research, and we do every day on the job. We try to research about the patients that we are seeing. But research is something which is systematic, and so it needs to follow a certain process. It involves collecting data, it involves organizing it, and then analyzing it. And when you analyze these facts, that's called evidence. And additionally, what it should do is that it should control for biases. It should identify where the biases are. I mean, if you only go for certain type of sources of literature, you may have a very great bias. So this is a cartoon. I'm just going to start with two cartoons. Basically, I've been here. This guy is saying I was just rubbing sticks and I got fire, and I didn't realize I was doing basic research. But in actual fact, this guy was not doing basic research. This was serendipity. He just did something and fire came. And so, fortunately, he was able to recognize that it could be used. And that's serendipity. There's another cartoon here which is about research. It's actually a caricature of research. So here, like these scientists are saying, you heard of the story like water off a duck's back is the phrase. So here they're testing all the things: milk off a duck's back, orange juice off a duck's back, acid off a duck's back. Poor duck. But this is a caricature. This is not the way research should be done. So medical research basically is of two types. One is called primary and secondary. So secondary is actually looking at other people's research and putting it together, and that will include things like meta-analysis, systematic review, and narrative review. The primary research can be basic when you're developing a new test, or when you're doing some kinds of studies using animals and cells, or when you're doing genetic and molecular studies. It can also be clinical and epidemiological. And there, if you have an experiment, that'll become a clinical trial. If it's just observational, it can be case control, it can be cross-sectional surveillance, registries, ecological studies. And Saurabh is going to give you a lot of talk about all of these in the next talk. So what are the characteristics of good research? The first thing, you start with a question. And I'm going to tell you how we start with questions. But you have a question, and then you clearly articulate what it is that you want. And you make a plan, you follow a plan. And then, all research, there's a problem that you're addressing. So divide whatever the main problem is into sub-problems. And then you collect and interpret and analyze the data. So when you choose a topic for research, the important thing is that one is you should choose a disease which is commonly encountered in your setting. In fact, that's what is most relevant to most of us. I mean, you might be a hepatologist and you'll be seeing a lot of patients with chronic liver disease. And there are issues in chronic liver disease that you want to check. And so you'll choose a disease which is common there. The second thing is, when you do that and you identify a question, then you do an exhaustive check of literature to understand the disease and identify the gaps or controversies. In fact, a colleague of mine who is a very well-known epidemiologist, he was on all the TV channels during the COVID pandemic, Dr. Jayaprakash Murli. When he talks about ethics of research, he'll always say the first thing you have to do is a meta-analysis. Know the literature well, otherwise you're going to end up doing things which are inconsequential or which have already been done. And then you decide which gap in knowledge you want to study. And when you've done this, then you need to look to other people. So I always feel that you need to discuss with others. You need to discuss with colleagues. They may be your seniors. They may be your peers. They may be your juniors. They may be statisticians. Find out whether what you want to do, is it feasible? And I'm talking about clinical or epidemiological research. This also is true when it comes to lab-based research, but the people that you consult are different. So if you're going to do research on a particular study in your hospital, let us say, first you need to know whether you're getting enough numbers of those patients. So try and get hospital records. See if the number is attainable. If you're going to do retrospective studies, you need to look through those records and see if all the information you want is recorded there. One of the major problems with retrospective studies is missing information. Of course, there are statistical ways to go over missing information, but still you'd like to have all the information complete. So the first step, as I said, again, survey the data. Usually the source for raising a research question, one, it is patient data. to it may be published papers. I mean, in your hospital, if you have a journal club, a review of a paper may raise a question, or it may be clinical questions, and they may be posed by patients, they may be posed by your seniors, they may be posted by your juniors during ward rounds and during meetings. So take a typical example. So here is a patient with acute pancreatitis in our ICU. And so when you're talking around, just standing around this patient with your entire team, and then you're saying, somebody says, how much IV fluid should I give? And what IV fluid should I give? And clearly you can go to the literature and see, but sometimes the literature is hazy on what it is. Sometimes the literature may have animal data, but not much human data. So another question, when do you start feeding? And if you start feeding, do you want to give oral? Do you want to give IV? Do you want to give nasogastric or nasojejunal? You know the answers to these questions, but I'm just giving you examples of some of the questions which keep cropping up. Every new batch of students that we have, these questions crop up. Analgesia. Is epidural better than intravenous analgesia? And interesting question, if you give epidural analgesia, will it shorten duration of illness? At what level does the blood pressure need to be maintained? Now, this is a constant battle I have with my intensivist. So in our hospital, acute severe pancreatitis is jointly managed by the gastroenterologist and by the intensivist. So every intensivist, every time they change, they change 3 times a day, each person will maintain the blood pressure, the mean blood pressure at the mean arterial pressure at a different level. And some will give a lot of fluids, some will give low fluids. And what I find is many of these patients, because there's an overload of fluid in the lungs, they end up needing ventilation for longer periods of time. So it's a constant battle we have. And then, they talk about, is cardiac output measurement necessary to monitor fluid replacement? My apologies for the spelling mistake there. So you're all familiar with the waterfall study, which looked at fluid resuscitation and acute pancreatitis. So it probably arose from questions like this. Now, when you have the data, then you need to survey the data. And this is Isaac Newton, you're all familiar with. And this is a quote that is always shown on Google. Isaac Newton apparently said, "If I have seen further, it is only because I stood on the shoulders of giants." And today, the giants are all to be found in PubMed, they are found to be found in Google, and increasingly they're to be found in ChatGPT. So the first thing when you start to do research is that you create a hypothesis, you make that into a research question, and based on the research question, you have objectives in your research. And I'll quickly go through each of these. So what is a hypothesis? I mean, you all know what a hypothesis is, but let me enunciate what it is. It's basically a logical supposition or an educated guess, which you're making on the basis of limited evidence. And you're trying to connect a cause and an effect. So the cause, let us say the waterfall study is volume of fluid replacement and type of fluid. So that is the cause. The effect is recovery. And so the cause is the independent variable. The effect is what you're interested in. It might be death. It might be the length of hospital stay. It might be the length of ICU stay, whatever it is. That's the effect. That's the dependent variable. There are two kinds of hypotheses. So there is the null hypothesis, which is known as the zero difference hypothesis. So here you say that by changing one variable, which is the independent variable, you will not have any effect on the dependent variable. So you can say it doesn't matter what fluid you use, the outcome is the same in acute pancreatitis. So that is the null hypothesis. On the other hand, mostly we use a research hypothesis to design an experiment. And the research hypothesis is written like if you do something, then this will happen. Because then it's easy to identify the independent variable and the dependent variable. and see how one affects the other. For instance, here, you will say that moderate hydration will reduce ICU stay and it will reduce mortality in patients with severe acute pancreatitis compared to overzealous hydration. So that is your research hypothesis. So based on this hypothesis, you convert it into a research question and make that question simple and clear. We heard Dr. Shobna, she said, make it simple, make it clear. So you can say, this is a different one, and I'm not going through the waterfall kind of study. But let us say, so one of my colleagues felt that we should give epidural analgesia to all patients with acute pancreatitis based on his experience with 2 or 3 patients. Why? He hypothesized that giving epidural analgesia immediately after hospital admission will shorten the duration of hospital stay and the duration of ICU stay in patients with acute severe pancreatitis, basically by reducing the cytokine storm. This is a hypothesis. I mean, anybody can create a hypothesis. This is fine. This is a good hypothesis. So how do you convert this hypothesis into a research question? So there are 2 parts to this hypothesis. One is that if you give epidural analgesia, it will shorten hospital stay. The second hypothesis is that it acts, this is the mechanistic part of the hypothesis. It looks at the mechanism, that it will act by reducing the cytokine storm. So the second part is dependent on the first part to be successful. So the research questions are, will administration of epidural analgesia to a patient with severe acute pancreatitis immediately after admission reduce the ICU stay and the length of hospital stay as compared to standard therapy? The second question, which is looking at mechanism, will this be accompanied by a reduction in levels of plasma cytokines in the active treatment group? Now, even if you showed this, it doesn't tell you that reduction of cytokines is the mechanism. All it tells you is that it happens together, that they are associations, but it doesn't tell you its cause. So when you formulate a research question, it's not simply just, you go read, you discuss, and you have a question. Every step, you go back and forth. You read and you discuss. After discussion, you go back and read again. Similarly, after discussing, you have a research question. After you make the research question, you go back and discuss, and you go back and read, and you come back. So it's multiple iterations are necessary. So let's look at a different hypothesis. So there is an observation, and the idea of this slide is to let you know that you can address the same hypothesis in different ways. So there is an observation which in many of my generation made, saying that IBD is rare in India compared to Western countries. That was true 30, 40 years ago. So the hypothesis from this is that IBD prevalence in Indians is low because they lack the genes that predispose to IBD. I mean, this is one hypothesis. Genes versus environment. So we are looking at genes. Now, if you want to look at the same gene pool, then the question that you're asking is IBD more common in Indians who have migrated to the West compared to their families in India? That is the same gene pool. Or if you want to look at the same environment but look at different genes, you will ask, is IBD equally common in Indians and in Caucasians who were born in the UK? And both these kinds of studies have been done. So there are what are called the finer criteria to define a good research question. So this acronym, finer, F stands for feasible. Is it feasible? Are there adequate numbers? In your team, do you have enough expertise? Is the cost manageable? Is the cost of research manageable to you? Is the research manageable in scope? I mean, if you can say, I want to do a nationwide study, is it manageable? Do you have enough of a team for that or enough people collaborating? That's feasible. The second is that I is it should be interesting. Like if it's not interesting, nobody is going to look at it. So it should be interesting to your colleagues and to the community. That makes it talked about. That gets it published in the NEJM or Science. So that's how it goes. Third thing is it novel? N is for novel. Are you repeating something done already or are you doing something novel? Always edge goes to something which is novel. Ethical. Now, all research should be ethical. Are you doing harm? The first thing to answer in any research study is, are you doing harm? Is there patient autonomy? Are you allowing the patient to decide what they want? Are you forcing them to do something? And the third thing about ethics is it generalizable? Is it, whatever you do, can it be applicable to around the world? And the R finally, is it relevant? Is it relevant to science? Is it relevant to health policy? See, a lot of us do research which actually finds its way into guidelines. For instance, you might want to see what is the prevalence of IBS or what is the prevalence of GERD in the community. I'm sure Dr. Shobna can talk about this. So that is relevant to guidelines and to health policy. And then when you face, so this is the finer criteria that we talked about with any research. So framing the research question, when you're talking about clinical research, then another set of criteria which people use, and particularly when you send it off to a funding agency, they'll ask you about the PICOT criteria. So the population, the intervention, the comparison group, the outcome of interest, and the time over. And I will just quickly look at this. So when you're working with this PICOT framework, the questions with population are, what is the target population? Is it a narrow or a broad population? Is it vulnerable? And you always worry about doing research on vulnerable populations. Ethics committees will be very strict about this. What are the eligibility criteria? And what is the recruitment strategy? With the intervention, is it treatment? Is it a diagnostic test? Is it a procedure? Is there a standard of care? Is this the most appropriate intervention? Is there a need to standardize the intervention? Are there potential side effects? If there is no intervention, what is the exposure? And then there's a comparator arm. So here, how has the control intervention been chosen? Are there ethics related to use of placebo? Has a sham intervention been considered? And then if you're going to do multiple comparisons, will statistical analysis be adjusted for multiple comparisons? And coming to outcome and time frame, outcome, what is the primary outcome, secondary outcome? Are they exploratory? Are they confirmatory? Would you think of surrogate outcomes? Would you think of clinical outcomes? Are they validated? Has safety been considered, etc.? And then will they be numerical, categorical, or ordinal? Will they be just yes or no, multiple categories or numerical? Is there enough statistical power? And then the time frame is kind of self-explanatory. And within this time frame, will you be able to recruit your patients? Will you be worried about dropouts? So these are all issues that we actually practically face in our research. So I'm actually going to wind up here and summarize. And in summary, basically what we need to do is to choose a condition which is common for any research. Be familiar with the current knowledge on this. Identify the gap in knowledge which you want to explore. Discuss with your colleagues and guide. Frame your research question clearly. Convert that into a hypothesis or convert the hypothesis into a question. Break it down into a number of objectives, and which is the objectives are actually is what you're going to achieve, and ensure that these objectives are realistic. With that, I'll stop. Thank you.
Sobhana, you would agree with me. Rama, I enjoyed listening to you. Sobhana is there? Yeah.
Yes, I am
Swapna,
here. I think Dr. Philip has also joined.
Philip,
Yeah.
I just introduced that you have been the editor of the Indian Journal of Gastroenterology and you have been the president. We are fortunate to have you as the research methodology thing. I'm glad that you could join it. We just introduced the topic, introduced the concept of ACG endorsed webinar. Then back to back two lectures we'll have it so that we'll take up the question. Some of the question which we received from the delegates, we already sent it to all of you. Philip, welcome to you. Okay. And now we have research methodology. We want your finer comments regarding research methodology, how to choose a research question. Philip, am I audible to you?
Very much, very much. Yeah, can you hear me?
Yeah, yeah,
Very audible, yes. I enjoyed Rama's presentation, learned a few things from there.
yeah. And is Saurabh ready or we should take up some question, Saurabh? Dr. Saurabh Datta? Phone button.
Let's see here.
He's just joining. He was held up in an emergency. He's there right now. He just called me. While we have some interesting question to all three of you. The speaker Rama and the other two stalwarts here, Sobana and Philip. What helps you decide whether a question is worth the time and effort? We want to see the fruits first, I think. The question has been asked like that. So, how do you decide, okay, this is a good question, we'll wait and watch? Or no, this is not a question to be taken at all. So, answer from Sobana, I will start. I welcome Devendra.
So, a good question, it depends actually on what you're looking at. So, suppose something is very novel or something is very simple but hasn't been answered earlier, would always be a good question. Something that is simple, the method is good. So,
Okay, now,
yes.
no. Saurabh, are you there? Saurabh Datta, you are not audible, Saurabh.
So in the meantime, can we just proceed
Yeah,
with
yeah,
what
Philip,
Shobna?
your answer about this is the
Yeah,
question
yeah.
is
Please, I think
worth
you
the
Just,
time.
continue talking because there's some disturbance in the.
yeah, in continuation of the point that Shobna mentioned, a research question should not be something like me too. You know, everybody else has done it, I also want to do it. Unfortunately, for many of our dissertation topics and thesis topics, people do that, a quick way to get over with it. But a research question should answer an intelligent, I mean, a research topic should answer an intelligent question where you think that this will add to maybe even a 0.001% knowledge in science. So something that has been done by everyone and I'm doing it just to finish a thesis is okay for a thesis. But a research question should answer a burning situation in your mind about why is there no answer to this? I think that's very important.
I appreciate that. Can I ask you, Rama, a pointed question? I like that everyone should start with a meta-analysis, then go for the research. So can you dilate upon that? So that you know about the literature thoroughly, what is existing, what is there already existing, what is new you are going to add.
Exactly, because you know what the gaps are when you do a meta-analysis. I mean, that's a very intensive way. It's for people who are deeply into research to do that. I wouldn't expect the average DM or DRNB student to do that. But a meta-analysis is a good way to tell you where the gaps are. Because that's when you know, when you looked at so many heterogeneous papers, you'll find this is deficient in that, that's deficient in something else, and so on.
The question to all the three stalwarts we had, Rama, Philip and Sobna, and Dr. Sorub also joining. I've seen American graduates, the fellows, somehow they get into systematic review and meta-analysis. I was interacting with the Babu P. Morgan, who is an expert in now meta-analysis. But why our graduate, undergrad, I mean our fellows and we are not into it. since you all have been teachers, so what is where is you can focus the deficit, or are we not insisting?
If I have to provide a simple answer to that question, Chandra, it
Yeah.
is not that is not interesting, it is that they are not interested.
So interest and interest. I know
Yes.
you
Yes.
will have a play of words,
No,
so
no, no,
more
no.
to
What I
go
mean
now.
is, for them, let's be practical about it. For them, the thesis or a dissertation is something that they have to do to get through their DM or DNB. It's not going to serve them in future unless they get into academics or research. So driving them to do something of interest to answer a question is more the responsibility of the teacher than the student. The student has no interest in that because 99% of them will not be using this. It's like us studying calculus and trigonometry in school. We've never used it after. In the same way, unless you have a thinking and a questioning mind, a research topic is not of relevance to them at all. So they're not interested. That's the reason why.
What is your thing about the Sobhana?
So I think I would just continue with what Dr. Philip said, is that the interest in the students has to come from within. They have to be able to ask a question. And if you encourage them to ask questions, those questions can maybe lead to small researches. Unfortunately, when you go and apply for a job, and that is what the ultimate aim of all the students is, either they apply a job or they go into practice. When they go to apply for a job at a private sector hospital, which jobs are more available than the government sector, the private sector hospital is not interested in your research. Whereas if you go for a job to a medical college, also for a professor's job, I mean, later on in life, all you need is 3 or 4 publications. It doesn't matter which journal, as long as it is cited. I know the criteria have been diluted so much that you could just put your article in some random journal and still get away with it to get your promotion. So therefore, the students are not interested. They will just copy
There
paste
has
from
to be a
a paper
sea
and go
change.
ahead.
Yeah, I agree with you. There has to be a sea change. The interest should
Yes,
come from within, number one. All should
absolutely.
inculcate that habit. And the interest right now, research should be only in academic premier or the government institution there. And the private institution also, we need to take it there. So, Rama, what is your suggestion? We need to take it uniformly to all the people, apart from self interest and other things.
Okay. So, when students come, they are like T lymphocytes. Some of them are naive lymphocytes, some of them are committed.
You
And
are
some are
answering
really
like a
committed
researcher.
to committed to clinical work and endoscopic work. The naive lymphocytes are the ones that we should try and condition. And there it depends on the teacher. Now, let me remind you, TSC, you're talking about research being done in non academic institutes. Now, let me remind you the waterfall study, which is published in NEJM, has contributors from the Surat Institute of Digestive Sciences.
Absolutely.
See, that is very important. So that's the reason motivated me. What a mistake. Some of you have been very fortunate to be in academic. I mean, everyone wants to be in academic, but not everyone can get a position into that. You are fortunate you were in KEM, you were in CMs, Vellore and other people. So, number one. Number two is the interest we need to create means the kind of the teamwork we need to create. So what I have done is to the ACG, we have 1,200 members. So Rama, what we did, the small volume centers also should be able to put in lot of efforts for research. So what I have done in this group is rope in all the people, the academic people, the centers will be the leaders, the small volume centers people, we create a momentum into this. And I've created a pan-India research study group. I got inspired by the Dutch study group on pancreatitis. Now they are the leaders in the all over the world. When I went to ACG recently to Phoenix, everyone was quoting about the Dutch paper because there are very small centers in Dutch land. That Dutch land is much smaller than ours. So they all joined together. So I given the name Pages. That is Pan India Research Study Group, Pan India Gastroenterology Research Study Group. So I appeal to all the stalwarts like you, Rama, Sobna, Sarob, and Philip to encourage. I want to enter some topics to each one. They will bring in all the things. You have to help them how to put it into this. So this is one thing. And I'm giving Saurabh to just do some work he's doing in computer and how to choose a question that is practical in a low volume center. Raman, this is you gave a talk about nice, very inquisitive. You have a large volume center, okay. In a low volume center, how will you do it?
So I would not know what you mean by a low volume center because see,
Okay, opposite of a low high volume center.
no, okay, all right. No, does it mean you see one patient a day? Is
No,
that
no, not
a,
one patient.
no,
Say 40 patients a day.
40 patients a day. So 40 patients a day over 300 days will fetch you 12,000 patients, right? And of the 12,000 patients, I would suspect that 50% have IBS or functional dyspepsia.
Very good.
Am I right? So under those circumstances, that would be a field of study. I mean, there's so much that you don't know about, say, functional bowel disorders, that makes up a large volume of that. So I'm talking about gastroenterology. So
Mhm.
you see what is the condition that you are dealing with, which is most likely to have reasonable numbers.
I think that point very important, like in your in a presentation is what you commonly see, regularly, routinely see after the 40, you see 20 liver cases, man. So you should start searching for an answer in a gap in the liver diseases. Instead of something in the group pancreatitis you see once a day. Now, before we ask Dr. Saurabh, are you ready, Saurabh? Dr. Saurabh, are you ready? Can you unmute?
Yes, I'm ready.
And now a
I've
question to
joined.
Philip, Swabna, and Rama. Do you start with the case study, case series, and retrospective study, prospective, or before case study you will go for the meta-analysis? How will you focus your? A lot of youngsters are watching this all over the world. They are all interested in writing papers and getting into research. So your answer, we start with the Philip now.
So just a clarification.
Hmm.
TS, you mentioned that 40 patients a day is low volume. For us, that is high volume.
Oh, okay, in that the 15 will be new and 25 will be old. It's still
All
that.
right. Okay, I'll take that point. The second thing that Rama mentioned is so important. If 50% of the patients in any consultation are functional bowel disorders, we still consider it infra-dig to do research on that, isn't it? There are journals that are published, like neurogastroenterology and motility, that are published entirely for functional bowel disorders, and there are scores of papers coming out every month on this condition. But we don't want to do that. What we should remember is we are not trying to catch up with the high finance institutions of the West. We cannot do that at all. We identify a problem that is unique to our population, which means primarily, like Rama said, select from the group of patients you see, presuming, of course, that you have a wide spectrum. So that is extremely important for us to select from the group of patients we see and not try to match with basic sciences and institutions from around the world who are funded for their research, which we are not. No institution in the public or private sector funds any research. You're shelling from your own pocket, and if you're lucky, you can get a government funding for that for a high project. That, of course, has its own loopholes also. But do something that you think you can do in your circumstances. That's important, like Rama said.
Okay, now we will start with the case capsule. Then there is a nice journal available, American College of Gastroenterology case capsule paper. I mean, they accept only the case capsule. Very surprisingly, it is done by whole the group of third year fellows and the young gastroenterologists. They run this journal. Just want to tell you that how ACG encourage research. Only we need to have an idea and our young postgraduates and fellows should become members of they should become members of all the national and international society, at least national society. They start reading the journal, as Rama put it. If you don't know what is already available, your research question will be as old as what already discovered. Somebody says, now I want to discover H. pylori or what causes ulcer. And that becomes, I mean, I'm just telling an analogy that bad. So I think some more questions need to be taken with Rama and other people. So may I invite Dr. Dr. Philip and Sobana to tell about Dr. Sarup we will invite to deliver his lecture, and Sobana is going to moderate the session. Since Philip was not there, so we'll also tell him that the designing a trial is very important. So how important? And you introduce the designing a trial, then you please invite Dr. Sarup Datta to deliver the lecture. Okay, Philip?
Shobna, you can do that.
Okay. So we started with how to ask a good question. And Rama told us many things. He also told us that when you design a study, you look at certain questions. Now, let's say you design a study and you don't look at the PICO or the other things that he mentioned. What will happen is that at the end of the study, you will realize that the data is incomplete and the analysis will also not give you the answer that you originally asked. Therefore, in order to get a good study, the first part is the question and the second part is the design. And for every kind of question, the answer to the design of the study is different. And therefore, we need to understand which design will work for which kind of question. And I think Saurabh is going to give us an excellent lecture on this. Saurabh, can you start?
Yeah, thank you. Thank you, Dr. Shobana Bhatia. I'll share my screen now. And I just wanted to know that in case I'm sure there are students who are attending this webinar. In case I want them to respond by putting something in a chat box, is that possible in this format?
100%. Chat box, only thing, and they should be familiar. It's available Zoom platform. Most of them they do so.
Okay.
Okay.
So is my screen visible? I'm going to make it full screen
And
now.
in case you don't get a question in the chat box, you please ask one of us will be like a student.
Yeah, because
Okay.
I may not be able to see the chat box while I'm presenting. So, Dr. Chandrasekhar, can I request you to just tell me about the responses coming in the chat box, if that is okay?
Response or any question you ask them, I will put forward the question or I will take up it. Okay.
Okay. Thank you so much. Thank you very much, Dr. Chandrasekhar, for this wonderful opportunity to interact with all of you on this GE webinar. So I'm going to be talking a little bit about study designs, what kind of designs are required for answering what sort of questions. So let me just get my laser pointer. Yep. Okay, so let's start with an imaginary date in the future. 4th of January 2027. This is the WHO bulletin. The WHO has reported an outbreak of a new illness near Chandigarh. There has been a cluster of unusual cases of an atypical rash, anemia, sensorial changes, and high-grade fever. So officials at the WHO have dubbed this the rash syndrome. As you know, before they do anything else, WHO first coins an acronym for every disease. So they've called this the rash syndrome. So investigations for all known infectious and immunological or vasculitic diseases have drawn a blank. The outbreak is spreading rapidly. New patients are constantly coming to the emergency department of the region's premier hospital, the PGI-MER. The WHO got to know that there's an enthusiastic group of research methodologists, including you, attending a GE webinar series, and they approached you for help. So what are the research questions that you would like to ask? So if it's possible, please write questions that come to your mind. This is a completely new disease. So any question, any research question is going to be a novel question. So please start typing in brief research questions into the chat box, and then I would request Dr. Chandrasekhar if he can read out some of those questions to me as you keep writing them. So I'll give you about maybe 60 seconds for this exercise,
Okay.
and then we'll move on.
What is the question you said? The chat
No,
box. Huh?
so this is a completely new disease. What are the kinds of research questions that you would like to ask about a completely new disease? You know, it's like COVID. When it first dawned upon us, it was a completely new disease. So there were a lot of research questions that people wanted to ask about the disease. So what are the questions that people would like to ask?
The age and gender and immunocompromised or immunocompetent host. They wanted to know that.
Okay.
Immunocompromised
What
or
more?
immunocompetent, age of
Okay.
the population.
Age and gender. Okay.
Gender.
What else?
And the economical status, poor or
Economic, okay. Economic, socioeconomic background.
Are
What
they
else?
taking some medication earlier, like steroids or immunosuppressive drugs?
Same as immunocompromised. So steroid would immunocompromise them.
And
Okay.
the previous history of such episode earlier,
Okay. Past history.
past history in the community. So that is outbreak of the already existing disease, which
Okay.
remained.
So how rapidly it's spreading in the community. Okay. What else? Any other questions?
And is there any uniformity in the symptomatology?
Okay. Is everybody having the same symptoms? Some extra symptoms, some less symptoms?
So organ specific, anything?
Organ specific? Are any other organs involved? Is it a multi-organ disease? Okay.
Okay. And where are they coming from? Urban,
Okay.
rural,
Geographical location.
Yeah.
Geographically, okay. Are they coming from everywhere or some specific geographical location? Okay. Yeah.
I think we are exhausted.
Okay. Okay. So, research questions to this novel disease, as you can see, I have put in some thoughts of my own, and you would have found that many of them actually coincided with what you thought. So here was on the top left a box of questions. Of questions, describing the disease. What are the clinical features? Some of you wanted to know what age and group and gender. How many days does the illness last? What proportion of patients are dying? What sequelae is it leaving behind? So these are questions that are trying to describe the disease. Top right is another box. Are there any risk factors of this disease? Are there any risk groups who are getting more of this disease, eating a particular food, exposure to another patient with this illness, which region did they come from, and so on? Bottom left are trying to diagnose this disease. Okay, what caused this disease? Is there a test that can diagnose this disease? Is there a clinical feature that can prognosticate the outcome of this disease? And bottom right are things that you can do to alter the natural course of the disease. Is there a medication or intervention that improves the outcome of this disease? Is there an intervention that could prevent this illness, prophylactically amongst those who are exposed? So these are the four broad bins into which all questions fall when you're dealing with a new disease. This is exactly what had happened with COVID. There were four broad bins. So one set of questions describes the disease. One determines the risk factors. One for diagnosis and prognostication, and one for prevention and treatment. And to answer these four broad categories of questions, we have certain types of research studies. Now, all research studies, at least the clinical research studies, can be broadly divided into two: those which are observational, those which are interventional. Observational research studies, we do not do anything to alter the natural course of the disease. We are just observing. Interventional, we are doing something to alter the natural course of the disease. Within observational, you have a category of studies which are called descriptive, in which you're describing a single group of patients. And they can be of two types. Either they are cross-sectional, in which case you're describing them as they were on a particular day of their illness, or it could be a longitudinal descriptive study or a descriptive cohort study where you are describing their symptoms over a span of time as the disease progresses. The second kind of observational studies are what are called analytical, where you're comparing two groups. So all analytical studies must have two groups to be called analytical, and they are broadly of three types. Cross-sectional, where the two groups are being compared at a cross-section of time, a snapshot of time, or they could be case control. Case control studies are those studies where the outcome has already occurred. So you're comparing the diseased and the non-diseased, and you're asking them questions or looking at the records. You're going back in time to see whether in the past they had been exposed to a risk factor or not exposed to a risk factor. So you're starting off with diseased and non-diseased in case control studies. And the third are analytical cohort studies. Don't mix them up with descriptive cohorts. So analytical cohort studies will always have two groups. Analytical cohort studies start off with a group which is exposed and non-exposed, and none of them are diseased to begin with. And then you go forwards in time to see how many of the exposed develop the disease and how many of the non-exposed develop the disease. Moving on to interventional studies. Interventional studies could be an interventional cohort where you're intervening in just a single group. You have no comparison group. And these are often, the very initial sort of studies in which you want to try out a new drug for the first time. You're just giving it in a few patients. And then once you have a fair idea that the drug is working, you move on to a controlled trial where you are comparing two groups of patients, one who received the intervention, one who did not receive the intervention. And amongst these controlled trials, there are broadly of three types. One is a comparison against historical controls. That means those who had in the past, not been treated, and you're comparing them with whom you're treating now. Or they could be parallel group, non-randomized controls. And finally, the pinnacle of all studies which have the least amount of bias, these are the parallel group randomized control, or the RCTs, right? And RCTs in turn could also be broadly classified in two different ways. One is, are these RCTs superiority RCTs? That means you're trying to show that one therapy is better than another therapy, or a therapy is better than a placebo. Those are superiority or randomized control trials. Or you could have something known as a non-inferiority trial, quite often where you have an established standard of care, and now you are either trying to shorten the duration of treatment, or you're trying to give oral instead of IV, and so on and so forth, where because of the the practical benefits of a shorter course or an oral course, you are willing to switch over to a shorter or oral course as long as not inferior by a tiny margin compared to your standard therapy. So this is one way of classifying RCTs. The other way of classifying is based on how the unit of randomization. They are either individually randomized or cluster randomized. Individually randomized means the unit of randomization is the individual patient. Cluster randomized means clusters of patients get randomized. For example, villages or schools or classrooms or hospitals get randomized. So everybody in the cluster gets the same intervention, and different clusters get different interventions. So this is the broad framework of all kinds of research studies that we deal with as clinicians. So let's have a little quiz. So we were talking about that outbreak of the disease that had happened in Chandigarh. So supposing I went to the communicable diseases ward where these patients were being housed. I went there daily for a month and saw those patients with rash syndrome. Each time I found out how many new patients were there. So I found out the following information of every new patient: the age, the sex, the duration of the illness, the type of rash, the maximum temperature until then, and the sequence of appearance of symptoms. So can you write your answer in the chat box? What kind of a study do you think this is? How did it fit into that overall framework of studies? So can I request all of you quickly within the next 20-30 seconds to write your answers in the chat box, and may I request Dr. Chandrasekhar to help me out once again. So just for your benefit, I'm just going back to the previous slide so that you can get an idea of what you need to write.
Okay, this is observational study, descriptive. It's a kind of a descriptive observational study. Whether it is maybe a cross-sectional also, because that's what the answer is. Huh?
Yeah.
So I think very clear about observational.
Yeah. So anybody who has written descriptive, observational, cross-sectional is absolutely correct. So let's look at this. So are we dealing with two groups or are we dealing with one group? So the answer is we are dealing with only one group. There is no comparison group here. So everybody out here, those who have been admitted in the communicable diseases ward with this rash syndrome, so we're dealing with a single group. So it's observational. We are not trying to change their natural course of the disease, and we are describing just a single group. So it's observational descriptive, all right. The question is it cross-sectional or is it longitudinal? Well, we are looking at all of these patients, how many new patients, and just this information on that particular day, age, sex, duration, type of rash. So I'm not following up each patient over time. So therefore, it is an observational, descriptive, cross-sectional study.
I think most of the panelists have written, Grish Kumar has written descriptive, Devendra Singh has written cross-sectional. So I think your slide
observational, descriptive, cross-sectional study. Yeah, so these three terms have to be there: observational, descriptive, cross-sectional study to completely describe this. Okay. So now I went one step further. I went to the communicable diseases ward daily for a month, which housed the patients with the rash syndrome. Each time I followed up the patients for the following: progression of each of the signs and symptoms, day on which the illness peaked, day from which the symptoms started improving, how many of the patients died and on which day of the illness, and the duration of hospital stay. So what kind of a study is this? So can we have some answers in the chat box?
Yeah, they want to see the slide again.
Okay. It will be tough to keep going back as we go ahead.
Yeah,
So it's observational, all right. We are still not altering the natural course of the disease. So it's observational. It's only one group.
So observational descriptive cohort.
Descriptive cohort, a longitudinal study. That's right. So this is an observational, descriptive, longitudinal or a descriptive cohort study. And the reason is that we are not altering the natural course of the disease. We're describing a single group of patients, but we are following them up forwards in time. We're looking at the progression, day on which the illness peaked, day from which, etc., etc. So we are following the patients up forwards in time. So therefore, it is an observational, descriptive, longitudinal study. Okay. We move one step forward. So I go to the communicable diseases ward and I compare patients with the rash syndrome and those with other communicable diseases that were lying in that ward. And I found out the following risk factors of each of those patients. I found out how many of them were obese, what proportion was obese amongst the rash syndrome versus other communicable diseases. That means I weighed them on the spot. I asked them whether they ate seafood or not. So what proportion generally eat seafood? And sorry for this living in Hamilton. This is actually meant for a different audience at a different point of time. So what proportion live in a particular place, say Mohali, Chandigarh, or Panchkula? So what kind of a study is this then? What sort of a study is this? And I'll go back again.
Yeah, this is observational. Our people are very smart, fast. Observational, analytical, compare two groups.
Because you're comparing two groups, yes. And the question is it cross-sectional, case control, or cohort? So now I am finding out their weight as it is now. I mean, I'm weighing them in front of me. Are they obese, not obese? I'm asking them, are you a seafood eater? Are you generally a seafood eater? They say either yes or no. And do you belong to so-and-so city? Yes or no. So I am looking at things as a snapshot. So this is an observational, analytical, cross-sectional study.
It is not case control,
study.
Not cohort.
It is not case control. It's not cohort. So it's an observational, analytical, cross-sectional study. Okay. So I go to the communicable diseases ward and I compare patients with the rash syndrome with those with other communicable diseases. And I found out the following risk factors. What proportion had been to a crowded place 3 to 15 days prior to the onset of the illness? and what proportion had eaten a poultry dish 3 to 15 days prior to the onset of the illness. So I had two groups, those with rash syndrome, those with other diseases. And in both these groups, I asked these two questions. So what kind of a study do you think I had done?
So this is analytical, descriptive, case control.
It's not descriptive because there are two groups. The
No,
moment
no.
you have two groups, it is observational, all right,
Yeah,
but it
observational,
is
sorry,
analytical.
sir.
It's no longer descriptive.
Observational, analytical, this is case control.
So this is a case control study
Yeah, this is a
because
case
we are
control.
starting off with those who are diseased and non-diseased, and we are asking them to go back into the past 3 to 15 days before their disease had started. Were they exposed to these risk factors, this crowded place or eating poultry? So when you're starting off with those who are diseased and non-diseased and going into the past, it becomes a case control study. Okay, so I then was not satisfied with just going to the communicable diseases ward. So I did a study in the community amongst patients who did not have rash syndrome. Nobody had rash syndrome. So I compared a group who had come into contact with a known case of rash in the previous 2 weeks with another group which had not come into contact with a case of rash in the previous 2 weeks, because I'm still not sure whether it's an infectious or communicable disease or not. It's still early days in the illness. So I compared these two groups and I followed up both the groups over the next 30 days to see what proportion in each group developed the rash syndrome. So the question is, what kind of a study is this? And write your answers in the chat box.
This is
So
again.
it's going to get more and more difficult to keep going back to this slide.
No. This is the
So
observational, analytical,
because two groups are being compared.
cohort.
And it's a cohort. So two groups are being compared. And which are the two groups? Those who were exposed to somebody with rash syndrome and those who are not exposed to somebody with rash syndrome. And then I'm following them up forwards in time to see how many developed the disease and did not develop the disease in the two groups. So therefore, it makes it an
Somebody has written comparative cohort. Okay.
Yeah, but it's just an analytical cohort. The standard term is it's an observational analytical cohort study. It's also good enough to just say analytical cohort study.
Cohort.
And sometimes if you just say cohort study, by default, it means it's an observational analytical cohort study. Okay.
Oh, cohort
So,
means
good.
analytical only, no? Okay, right.
Usually in common parlance, actually there could be either a descriptive cohort or an analytical cohort or an interventional cohort. When you don't clarify, by default, it means you're referring to an analytical cohort study, generally. That's the usual understanding.
Yeah.
So now, some other research had been going on side by side about this disease. So bench research. So from the cohort study, I realized that it was an infectious disease. Now, bench research subsequently showed that the classical cases of rash syndrome were due to a novel virus called the LOB virus. The gold standard for detecting LOB virus was viral culture, but this was expensive, difficult, and time-consuming. So an antigen-based bedside test was developed by a pharmaceutical company. And you can see, shades of COVID in all this. So I conducted a study in which every patient with a tentative diagnosis of rash syndrome, means not proven, not for sure, was subjected both to a viral culture as well as the antigen-based test to see what proportion of subjects with the viral culture were antigen positive and what proportion with the viral culture negative were antigen negative. So what kind of a study was this? It's a bit of a tricky question. I want your answers in the chat box.
Okay.
So where
they
does
want
it
to see the
fit
slide
in?
again.
Yes. So where does it fit in?
So we already exhausted this. So they are telling interventional now.
No. So we haven't done any intervention, right?
Any intervention.
We
So
have not given
blood test
any
is not an
medication.
interventional.
Yeah. So doing a test is not an intervention because you're not changing the natural course of the disease simply by doing the test. So let's be very clear about that.
So this is observational, analytical, and cross-sectional only again.
Yeah, so this is a specialized type of cross-sectional study known as a diagnostic test accuracy study or a DTA study. So all diagnostic test studies are essentially cross-sectional studies. So it's observational, it's two groups, and the two groups that are being compared are those which are viral culture positive, those which are viral culture negative. And it is cross-sectional because the antigen test is being done at the same time as the viral culture. So in all diagnostic test studies, it is assumed that the diagnostic test is being done at roughly the same time or within the same time window as the reference standard or the gold standard test. Okay, so diagnostic test studies are a special kind of analytical cross-sectional studies. Okay, so the biological characteristics of this LOB virus were rather similar to another viral illness whose drug of choice was dragonavir. So I thought, okay, why not try out dragonavir in the next few patients with antigen-proven rash syndrome? So after taking informed consent from these patients, I administered dragonavir to the next 10 patients and recorded their clinical course. This is the first time anyone in the world had used dragonavir. So next 10 patients with rash syndrome, I tried this out. So what kind of a study is this now?
So interventional.
What kind of a study?
Again, the slide should come.
Okay. I
For
should have
every
had
question, you
multiple.
can add this slide. So it is intervening in a
Okay.
single
So
group.
interventional. So for the first time, we are actually doing something to try and alter the natural course of the disease. Till now, we were not doing anything. So it's interventional. We all agree to that. So what kind of interventional? Is it two
Interventional
groups or
cohort.
single group? So it's an interventional cohort because there's just a small group, 10 patients. You know, some people would call it a case series. A case series is a common term used for this. First few patients in whom you're trying out an intervention are an interventional cohort. You don't really have a comparison, formal comparison group. You're just trying to see for the first time whether the thing works at all or not. So this is this was a small interventional cohort or a case series trying, looking at the effect of dragonavir. The first time somebody would have tried out remdesivir or somebody would have tried out some monoclonal and reported a few cases in a journal, that would have been a case series or an interventional cohort. Okay, so I went one step further. I had already administered dragonavir to 10 patients and recorded their clinical course. I had the data of previous patients who had not been treated with any specific antiviral medication. So I compared 20 such previous patients with the 10 who had received dragonavir for the following: the proportion who had died, the time to death, time to recovery amongst those who survived, and the sequelae amongst those who survived. So what kind of a study had I conducted?
Historical, analytical, interventional.
So it's interventional because we are trying to alter
intervention.
the natural course of the disease. And now it is two-group comparison. So it is now for the first time a controlled trial because there is two groups that I am comparing. But who am I comparing with? I am comparing with historical controls.
Historical.
Those in the past who had not been treated. So this is a controlled trial against historical controls. It is controlled because there are controls, but those are historical controls. Okay. So from my previous study on historical controls, it appeared that dragonavir administration resulted in better outcomes. However, a colleague of mine criticized this study, saying that patients who had been managed early on in the course of the epidemic had received a far lower level of supportive care. So he was a very combative colleague who liked to criticize everything that I did. And since not all doctors were administering dragonavir, I decided to compare my next 10 patients to whom I would administer dragonavir to the next 10 patients of my critical colleague during the same period in the ICU. And they were all getting the same standard of care now, no historical controls. And I was going to compare this 10 versus 10 for the proportion who died, the time to death, and those same outcomes. So what kind of a study was this now?
Interventional comparative control.
So interventional, yes.
So our people are writing faster. The moment you tell the question, they are writing. So interventional comparative.
So it's interventional. So it's a controlled trial And it's a parallel group control trial because it is happening in parallel. It is not a historical control anymore. It's parallel group, but it is non-randomized. Why do I say it's non-randomized? Because it was based on the whim of the doctor. I decided to give it to my patients. A colleague decided not to give it to his or her patients. So it was not a randomized control trial, although it was parallel. It is going on in parallel. It's not a historical control. So the results of that were exciting. All of my colleagues were now convinced that we were really onto something and that Dragonavir was possibly working. So we now planned a study in which all subsequent patients with proven rash syndrome would be allocated to a Dragonavir arm and a placebo arm by a random process. And the two groups, and the random process could be, rolling a dice or tossing a coin. It could be anything like that. The two groups are now compared for the same outcomes, the proportion who died, time to death, and so on, blah, blah. So I think there's no prizes for guessing this one. So this is a parallel group randomized controlled trial. So all randomized controlled trials have to be prospective. There's no such thing as a retrospective randomized controlled trial because you can only randomize prospectively. So this is an interventional study. It is a parallel group randomized controlled trial.
So they have written
And in this case, because there is a placebo arm and hopefully the placebo looks exactly like the Dragonavir in its appearance and how you give it and so on and so forth. So this would also be a blinded, so it will be a randomized, blinded, controlled trial. Okay. Now, Dragonavir worked and I managed to get a publication in the Lancet and I promptly added to my CV. The only problem was that the duration of Dragonavir that we had been using for so long was rather long. We were giving it for 3 weeks and it had a lot of adverse effects towards the end of the course. And I wondered whether giving a 10-day course would be almost as good as the 3-week course. So I planned a study to compare two durations of Dragonavir to see whether the 10-day course did not increase relapses of the rash syndrome by more than a very small margin, acceptable margin, and to see whether the 10-day course significantly shortened hospitalization, significantly reduced costs, significantly reduced adverse effects. So, and the patients would be randomly allocated to these two interventions. One is the standard duration of 3 weeks and the new intervention, which is just a 10-day course. So what kind of a study had I performed?
Okay.
Please write your answers in the chat box.
Yeah, somebody has written non-inferiority RCT interventional, or the other thing, they want to see the slide once more. So I think hereafter you must have that slide after each question.
After each question. Yeah. Yeah.
Yeah, that is
So anyway,
the word.
for the last time.
Okay.
Yeah, so we are at here. We are intervening. It's a controlled trial. It's a parallel group randomized controlled trial. And so there are two types of parallel group, superiority and non-inferiority. And as somebody has already mentioned in the chat box, so this is a non-inferiority, typical non-inferiority trial. So you already have a standard of care, 3 weeks. You're now trying to give a shorter duration and as long as it's identical to 3 weeks or it is increasing relapse, but by a very small margin, you're willing to switch over to 10-day course. You know that supposing the increase in relapses is just say 1 or 2%, I'm okay with it because the 10-day course has so many advantages. It shortens hospitalization, reduces costs, reduces adverse effects. So this is a classical non-inferiority trial. You're willing to accept a slight increase in relapses. For all you know, it may be similar or occasionally even better than the standard course. But even if it increases relapses by a very small margin called the non-inferiority margin, I am okay with it, if it's within that margin, as long as it has definite benefits like shortening hospitalization and so on. So that's a non-inferiority trial.
In this context, can I intervene, Saurabh?
Yes, please.
When vonoprazone was introduced few months before, a year before, most of the studies, so we become very familiar. They become already PPA is the standard of care.
Yeah.
proton pump inhibitor. So when they came out with this vonoprazan, most of the studies are non-inferiority or CT interventional study. Just wanted to tell you that how
Yeah.
a standard
So,
of care and new drug.
usually, non-inferiority trial will be done when there is a standard of care, and the new drug is either cheaper, easier to administer. It can be given orally rather than parenteral. It has a shorter course, and so on and so forth. So there are some very obvious benefits of the new treatment, and therefore you are okay if the new treatment is at least as good as the previous one. You're not trying to show superiority, even if it's not superior, but as long as it is equivalent or even within a certain non-inferiority margin, you are okay shifting because it has some very, very obvious benefits. Okay, so now I did that non-inferiority trial, and the shorter course of Dragunavir worked, and it was like magic. So I got it published in NEGM and added this also to my CV. But somebody pointed out that drug treatment alone was not a magic bullet. It was equally important to prevent the spread of this infection between hospitalized patients by using alcohol hand rubs or chlorhexidine hand rubs, but it wasn't clear which of these two hand rubs would be superior, because the two different hand rubs have different ways of acting upon microbes. So randomly allocating some patients in my ward with LOB virus infection to alcohol hand rub use and some others to chlorhexidine hand rub use would be very awkward, because it would be and cumbersome. Bed number 1 would be getting alcohol, bed number 2 would be getting alcohol and rub, 3 would be getting chlorhexidine, 4 would be getting again alcohol and rub, all within the same ward, would be all very confusing. So what I did was I decided to rope in 20 centers all over India that were all dealing with LOB virus infections, and randomly allocated the centers to use either alcohol hand rub exclusively or chlorhexidine hand rub exclusively. So I compared the alcohol using centers versus the chlorhexidine using centers for the rates of spread of the rash syndrome in their hospital, means rash syndrome acquired while in hospital stay, and secondary infections. So I think you all guessed it. So this was a cluster randomized controlled trial. Cluster randomized controlled trial. So it's an interventional study. It is a parallel group randomized controlled trial. But the unit of randomization is now no longer the patient. It is a cluster of patients. So this is a cluster randomized controlled trial. And it has certain caveats when you're calculating sample size and analyzing the results in a cluster randomized controlled trial. So the take-home messages for tonight are, broadly speaking, studies are either descriptive, which involves only one group, which is generally used for generating hypotheses. They are very preliminary studies. Analytical, where you're comparing two groups for risk factors, remember. And one special type of cross-sectional study are diagnostic studies. Or you have interventional studies in which you're trying to change the natural course of the disease. Cohort studies go forwards in time. CCS, that is case control studies, go backwards in time. That means you're starting with disease and non-disease and going backwards in time to look at the risk factors. And randomized control trials are broadly classified as either superiority or non-inferiority, depending on whether you want to show one treatment is superior or it is almost as good as the standard treatment, and either individually or cluster randomized, depending on convenience of doing the individual versus cluster randomization. What is the sad part of the take-home messages? The WHO did not know that there were such brilliant people attending the GE's webinar, and they would have come up with such wonderful questions. Okay, I'm happy to take any questions from the participants.
Okay. Saurabh, is fantastic. You are a great teacher. And in the Zoom platform also, you can engage so many people. And really, I liked each and every word of yours, the slide of yours, and the two important slides. The first slide you showed it, and the last slide summary and take home slide. So how it is really summarized. And the people are more going to do research after attending this webinar. And over to Somana. Then the format is like that. Both the speakers are available, both moderators available. Now what we'll do is,
So I'll stop sharing.
yeah, we will start with the panelists before Sobana gets ready. Dr. Grish, your question and comment.
Yeah, my question to sir is, what is about ambiseptic study? Whether it is having any role in this study, ambiseptic study, which can go retrospectively and we can also give the data prospectively. Whether it is having any
Yeah.
relevance, and what is the stand of this retrospective study in current scenario?
Whom are you asking, Rama or Dr. Saurabh? Both.
Dr. Saurabh, it is
Both.
Dr. Saurabh, sir.
Okay, right.
Okay. Yeah, thank you for that question. So by ambispective studies, we are basically referring to cohort studies. So cohort studies, I didn't go into that detail, can be of three kinds. It can be a prospective cohort, a retrospective cohort, or an ambispective cohort. And easiest to explain it by an example. And unfortunately, my examples are going to be neonatology examples, not gastroenterology, because I'm a neonatologist. So, we all know that birth asphyxia, I mean, it's a baby not breathing at birth, is a risk factor for developing cerebral palsy. Cerebral palsy is usually diagnosed about a year to a year and a half of life. So some time, has to elapse before the symptoms of cerebral palsy emerge. Now, if I were to do a prospective cohort study, what I would do is I would, from today onwards, assemble babies being born in my hospital who are either asphyxiated at birth or not asphyxiated at birth. That means they are exposed to asphyxia or not exposed to asphyxia. And I will now follow them forwards from today onwards for the next year, year and a half to see how many of them develop cerebral palsy. And then calculate risk ratios, odds ratios, whatever. And then that is a prospective cohort study. A retrospective cohort study is that I will say, okay, let me go to the medical records department of my hospital and open the files of newborn babies who were born more than a year and a half ago in my hospital. I open those files and I identify those who are asphyxiated, those who are not asphyxiated, right? That's how I assemble this cohort, which is in the past. Now I open their follow-up clinic files, assuming they've all been following up in my hospital. I open up the same patient's follow-up clinic files to see how many had got diagnosed as cerebral palsy, no cerebral palsy. So this is called a retrospective cohort study. The starting point is still exposed and non-exposed. The starting point is not cerebral palsy, no cerebral palsy. Starting point is exposed, not exposed. And then I open the follow-up clinic files to see. Ambispective is I recruit patients who are born not 1.5 years ago, but only 6 months ago. So 6 months ago, I go to the medical record department, open the files, and I find out how many are asphyxiated, how many are not asphyxiated. Now, only 6 months have elapsed. 6 months is not enough to develop cerebral palsy. So from now on, I follow them up for 1 more year to make up the total 18 months of follow-up or 1.5 years of follow-up. And at the end of that 1 year, I find out how many had cerebral palsy and did not have cerebral palsy. That makes it ambispective. That means a part of it was retrospective. I assembled them, from the record 6 months ago, but I followed them up forwards in time from even beyond from the current point onwards. So that makes it ambispective. I hope that makes it clear.
Yeah, exactly.
I think, okay, now next is Devendra, your question to the speakers, both the speakers.
Yeah, sir, my question to Dr. Ramakrishna, sir. Dr. Rama, as you alluded to doing a meta-analysis before you actually look for some question, in private sector, basically where the research is, always it takes a back seat and commerce takes the primary seat, the front seat. And in such scenario, do you feel that doing meta-analysis, of course, a very, very time-intensive thing, can AI or these things, the things which are coming up, will help us, selecting a pertinent question, and it will help us find out the gaps in knowledge and will guide us to, lead to effective research. Can this be a reality in future, sir?
Excellent question, Devendra. And I can tell you that I came from an academic institution to the private sector, and with the intent that I will get research into the private sector as well. And so I have experience of both. In the private sector, you're absolutely right that the candidates have different focus. And certainly AI helps. I think and that's why I put chat GPT out there. It actually gives you a lot of information. The only problem with that is that you have to sort out what is genuine from what is not genuine, because ChatGPT gives you a lot of information, and sometimes what it puts together is false, because if you go to it and you dig a little deeper into it, then it turns out that's the same. So when you have your students use the chat GPT, make sure that they go and validate what chat GPT says by using another not, I wouldn't necessarily say another AI tool, not like Gemini, but to use the usual thing which you have, for instance, the Google search engine or PubMed, and to see whether you can validate it, because ChatGPT just takes random things from somewhere and puts it to you.
How about Perplexity?
Thanks, sir.
Rama, how
I
about?
haven't used it, although I have it on my phone. I
Seems
haven't.
to be nowadays everyone is a little
I
more
use-
Good, sir.
specific than that.
It-
Raju, your
Sir,
question
I
to the
use
Raju, your question to the
Yes, sir. Good evening.
Yeah.
First, Rama sir and then Saurabh sir. Rama sir, I wanted to
And
ask.
I request all of you be brief so that we
Yes.
have around 20-30 questions to be covered. Okay.
Sir,
Yeah, Raju, please.
yes, sir. Regards from myself. Sir, Rama sir, I wanted to ask, for a person like me who has a 90% predominant practice in the individual OPD and procedures, do I select a topic which is a gap in the literature, or should I go with a topic which is actually, as everyone says, the most common of your presenting complaints in the OPD or the presenting syndromes, or I should go purely and get attached or with a senior person to take their guidance and then only go ahead? Can I do something individually and present somewhere?
I think you should certainly do something individually. I think it's very important first to get your feet wet. When you learn to swim, first get your feet wet. And so you start with something. Start with something simple. It doesn't matter. In fact, this is what I see with all the DNB students, that even if they are replicating something which has already been done elsewhere, it really teaches them the basics of research. You know what, that you have to assemble the data, that you have to do it systematically, that you have to analyze it, you have to validate it. So I think that is the thing. So you can start with anything. I mean, you can start with a single case, you can start with what is most common in your practice, but just get your feet wet.
Thank you, sir. And Saurabh, sir, one question to you. What if the person's consent cannot be taken easily, or the person is lost to follow-up or something? Can I still include their, endoscopic findings or images or literature in the research, or do you think we should skip that patient?
are you talking of a study that is being done prospectively, or are you looking at retrospective data?
So,
Because if you're doing anything prospectively, then you have to have consent. I mean, there are no two ways about it.
okay.
If you are doing a retrospective study, that means these patients had already been admitted in your hospital, they are now discharged, they have gone home, then a lot of ethics committees would give waiver of consent. That it's
Okay.
simply not practical now to be going and taking consent, as long as these patients are all, de-identified in your publication. There's no way of tracking, who's done what, right?
Thank you so much.
So if it's completely retrospective, most ethics committees would give waiver of consent for that.
Okay.
In our hospital, we still have to approach the ethics committee for the waiver of consent. That formality has to be gone through, but generally there would be waiver of consent.
But you need to possess that or have that waiver of the consent. Keep it for any verification future somebody asks, no? You
Yes.
should.
Yeah.
Okay,
Yes,
Dr.
so-
So
Bobna?
if there's any
Yes,
any
so-
prospective component, there cannot be a waiver of consent. You'll have to take consent.
Yeah. So I just add to that whenever you want to put patients' pictures, especially their face, we have to have complete consent. Though you will cover the eyes, You will do a lot of things, but still there you have to have consent. For
Okay.
other things, if you're showing a lesion on the hand and endoscopy picture, you could try getting a waiver of consent. So that's very important.
But face,
Yeah.
if you blind it also, you need to have the
You
permission.
have to have it. Yes, it's quite easy to identify.
So
So
easy to with the eyes closed or eyes masked also.
yes.
My colleague, Dr. Yogesh. So, okay, now we have questions now. That
From the
who
audience,
typed it? No,
yes,
he is randomizing the patient to placebo ethically right. The question to Saurabh and Rama and Sobana is my question from my colleague Raju Yogesh. Randomizing a patient to a placebo ethically right.
Uh,
So I'm glad you asked this
do you
question
want me to
because
take the question or?
I
Yeah.
think Saurabh, you
We'll
take
have-
it because I was going to answer it from a different perspective, but I think you start it and then I'll add on.
Yeah. So the question is, when is a randomized controlled trial justified? When are you justified to do a randomized controlled trial? So you are justified in doing a randomized controlled trial when there is something called clinical equipoise, or in modern terms, there's another phrase used, that is substantial uncertainty. That means the question has not been yet settled one way or the other. Whether the drug works or does not work, that question has not been settled. So we do not know. Only in a state where you do not know whether it is clinical equipoise, it is justified to do a randomized control trial. If it has already been settled, if therapy for H. pylori is a standard of care, you cannot then do a randomized control trial comparing treatment versus no treatment. It becomes unethical because everyone is supposed to get that. Now the question is, if RCT is justified, in the control arm, when can you use a placebo and when are you supposed to use the current standard of care? So if a standard of care is already available, then it is unethical to do a placebo-controlled randomized control trial. You have to be comparing your new intervention versus the standard intervention, right? If there is no standard of intervention, only then are you justified in doing a placebo-controlled randomized control trial. So for example, in severe COVID, it was ethically justified to compare dexamethasone versus placebo because there was no standard of care for treating severe COVID, so it was justified. Once dexamethasone becomes a standard of care for severe COVID, you're trying out a new treatment, say a new antibody or something like that. Now you have to compare it against dexamethasone. You cannot then compare it against placebo because you'll be depriving the placebo arm from a standard of care which they are supposed to get according to current standards. I hope that clarifies
I
this
think it's
question.
very clear. I think I brought in a COVID thing very appropriately. If any disease with a standard of care is already available, you can't introduce the placebo. And the standard of care is not available, treatment is not settled, then you can have the placebo. So you want to, Rama, your take from this question?
Yeah, so I would answer it slightly differently. That I think absolutely Saurav is right. But the issue is that you do have placebos in a randomized controlled trial, but you will have standard of care in both arms. And there will be rescue therapy in case something fails.
Okay, it's a little more complicated. That means
Yes.
both arms will have the standard of care.
Yes.
In addition to that, whether additional treatment is more effective, one arm, and the additional treatment is whether effective or not, the placebo in one arm.
Absolutely.
Suppose the one getting the placebo therapy, there is something going wrong, then
You have one in either arm getting something wrong because it's blinded.
okay, that time you have to go for rescue therapy.
Rescue therapy, yes.
Yes.
So it is not
just
stoppage rules.
Oh, that is very clear.
Yeah.
So
Yes.
research methodology is not that easy. Okay, one webinar you attend, you become a master. It makes it very interesting. Sobana?
Correct. So I'll tell you. So there are many diseases which have a very high placebo response. So let us say functional dyspepsia. If you don't give them any treatment, at least 20% or 30% will have a placebo-related response. So in these conditions, where there will not be any additional mortality, or any complication if you don't give them treatment, a placebo arm is justified in the first few weeks of the trial, or sometimes even for the long term, because you want to know what the placebo is doing. Unfortunately, there are some diseases, like, for example, ulcerative colitis. If you don't do anything, also at least 10% will respond. Then in that case, some of the FDAs will insist that there is a placebo arm in the first 15 to 20 days before a drug is started. And that is where this query really arises. Should we use pure placebo, or should we go to a standard of care for the comparison?
Okay, now we have 10 minutes to go, 12 minutes. We want to have a rapid fire here. The question is, which is the best study design for a beginner where much of statistics are not involved? Dr. Saurabh?
Well, I guess for a complete beginner, a descriptive study is the best place to start. You'll have the least amount of statistics, all very simple, just mean, standard deviations,
Okay.
medians, and quartiles,
Question
and
2 to
percentages.
Dr. Yeah, I understand. Question 2 to Rama. How much statistic a clinician should know? Minimum.
Minimum, they should know mean, median, mode, standard deviation, descriptive statistics. They should know.
They should know. Beyond that, it is an additional bonus.
Beyond that, it's additional bonus. Yes.
Absolutely.
Okay. After that, you can lean on a statistician if you want.
They should know distribution. The
Okay.
normal
Number 3 to Dr. Sobana. How much the computer can or Google can help to choosing the statistical, or we need to approach a statistician.
So it's always for a simple study, the computer will help us. And there are many websites which will tell you, if you enter the question, they will tell you what kind of analysis you need to do. But very importantly, both Rama and Saurabh mentioned about the type of study, the type of questions. But when we plan a study, at the beginning of the planning of the study, we also mention what statistical test we will use to analyze the data. So that is done upfront. It cannot be done later on. So this planning, and that is why you need a statistician for a complicated study. For a simple study, it doesn't matter.
Okay, a little more ultra short answers. How important or how bad or good the negative the results in a study? Do the journals accept it or not? Saurabh?
If you have gone stuck to protocol, your protocol is publicly available, you have stuck to the protocol, you have recruited the number of subjects required for answering that question, then a negative study is also provides a lot of information.
Can you explain what is publicly available means?
That means if you have, say, put up your protocol on the CTRI website, the Clinical Trial Registry of India website, or you have published the protocol, everybody knows what you had planned to do, and you did recruit the number of patients that was supposed to be recruited, then a negative study also gives a lot of information.
In fact, there is
The trouble is that if you do a very small study, a small sample size, much less than what was actually, it was an underpowered study, and therefore you got a negative result, then it's a problem, because then journals will be skeptical about accepting it.
But there was
Because then the negative result is simply because the study was not powered to even pick up that.
Okay, thank you.
Difference.
And there was a whole article issue on American College of Gastroenterology, Red Journal. Negative is also positive. I think I draw the attention of the postgraduate to go through that. Rama, for retrospective study, can we skip ethical approval if data is de-identified?
Yes, you can, but you can get waiver of consent, and most ethics committees might approve that.
From the ethical committee.
Yes.
And you have to keep it with you ready. Okay. Is there any online course for learning research methodology? If so,
Many.
many.
ICMR website has a full course.
How to select the sample size, Rama?
So
What is the
sample,
minimum sample size you need?
so sample size depends on your study design. So it depends on
Okay.
what question you're asking. And so there are publicly available sample size calculators. I mean, the formulae are there. They are a bit complex, but you have publicly available sample size calculators.
And the question to all three of you or the panel is also how to obtain, how successfully to get the research grants.
I think Rama and Saurabh have obtained significant number of grants. They should answer this in detail.
Yeah. So the one thing is your research grant. If you to be successful, you have to have the first thing is one is there's something called grantsmanship. So basically, you've got to put all the things together. You have to have everything should be brief, including the background. The aims should be clear. The objective should be clear. The hypothesis should be clear. That's very important. Everything should synchronize with the title of the study that you're saying. And your plan should be feasible. You must show that you have the expertise, that you have the background to do whatever you're proposing to do. I mean, if somebody suddenly, if I were proposing to do, research on ships or something like that, then obviously I don't have the background for that. See, they know that. I think those are some of the things, and your budget should be reasonable.
Okay. Saurabh, how successful? I mean, you are successful. How others to be successful? What's your mantra?
I don't have a one-line answer for this, but one important thing is start early. I find a lot of the times what people do is in the last minute they're trying to put together a grant proposal, just to beat the deadline, and that's where things go wrong. So, everything requires time. You need to devote time to framing the research question, for framing your objectives properly, for thinking it out, how a methodology will happen. It always helps to have diagrams, flow charts, a pictorial way of showing the timeline, the Gantt charts, and so on. It always impresses people who are reviewing, because then they know that there's been some clarity of thinking and time has been put into the thought process.
So early
The
start
more,
and presentation is the key.
yeah,
Okay.
Yes.
So that is the
Yes.
one.
So just a quick one, TSC, I'll just add that for those who are in touch with undergraduate students, ICMR has what is called as a short-term studentship grant, which is given to UGs. Second and third MBBS students can apply with a teacher, and they get maybe 25, 30, 40,000, but they get a small thing they can do. And it's very useful because they learn how to do research at that stage itself.
I think we need to have create an awareness among our students. And I got
Yes.
a person who came from Australia. He came for a 2 weeks mentorship. So I was just going through the biodata of the third year MBBS, that is the pre-final, and she has already published 12 papers. So I
Absolutely.
asked them that this is part of the routine. We don't take it as a great kind of research. It's a part of the routine. We keep doing it. I think that kind of we have somehow our students developed a phobia, or they don't have the liking. Research is only for a very high level thing. Even small level we can do that. She had done one in the Pilgrim Center, where whoever visited she had done the research. So this is just a message. And the last 5 minutes to know more about your personality. So I'm going to ask that. What is the last non-medical book you have read, Rama?
I read a lot of non-medical books. I'm just trying to recollect what the last
Okay,
one.
okay. When you read in plenty, it becomes a problem then.
Yeah.
While you are recollecting it, I'll ask Saurabh.
I read a huge number of non-medical books. I'm
So
constantly
that
reading.
means you want to do research, means you should read lot of non-medical
Correct.
books too.
So
I think
currently,
Yes.
I'm reading Gitanjali Shree's Tomb of Sand, which was the
in
Booker
Bengali,
Prize. No,
Booker
no,
Prize. Okay,
it
okay.
was Booker Prize winner.
Okay.
Tomb
Gitanjali,
of
the
Sand.
people say difficult to understand. Is it true?
Yes.
No, it's very lively way of
Okay,
writing.
right. Because you understand.
Gitanjali Shri.
Okay,
Gitanjali
right.
Shri.
Oh, Gitanjali is Sri.
Okay.
Rama, you have recalled and
Yeah,
recollected.
just to answer your question, the last book I was reading is actually is fiction. It's
Ah,
called The Law of Innocence.
Okay,
by
very
That's
good.
a nice book. That's a nice book. Yeah.
Okay, Swapna, you?
So currently I'm reading a book which says the one who tells the best story wins.
Okay, okay.
It's about how to tell stories. And it's
Oh,
a
very good.
beautiful book.
Storytelling. That's very vital,
Storytelling.
actually.
Very
And
vital. And
Devendra, your last book, non-medical book.
Skin in the game, sir.
Huh?
Skin in the game.
my
Okay, right. Greece, your last book. Okay. Greece.
Sir, I have not read a book. I am reading the only the books, but I am looking for the singing and because I have a
Okay,
means
you are a
interest in that.
singer. Okay, right. Now, who is your hero in life, Rama?
Who is my hero in life? Okay, I have many heroes.
You have everything, many, Rama. That's why you wear many hats, I think.
No, at different stages of life, at different stages of life.
Yeah, I think that's the right answer. Every stage. What stage? Okay, now who is the hero now?
Now I can't say who it is, but I would have say sometime back I would have said I would have said Kapil Dev because I mean he's a guy who was an all-rounder. He put his heart into everything that he did. He was a great batsman. He was a great bowler, and he gave
So
everything.
he get the facelift or the visibility to Indian cricket,
Yeah,
and is a simple person to move with, and
absolutely.
he started with nothing and kind of thing. Oh,
Not
Saurabh, who is your
not
hero?
Harmanpreet Kaur.
Who is your hero? Saurabh?
Not Harmanpreet Kaur, no.
Has been Corona.
No, no, he's saying
Okay.
Harmandeep Kaur.
Harmanpreet Kaur.
Harmanpreet Kaur, the
Oh, that
captain
is
of the
because
ladies.
see one
Cricket
thing.
captain.
Okay, Saurabh, Sobana, your hero.
Used to be Ratan Tata.
Oh, now also continue to be because it inspires so many people.
He's a great
He's a kind of
inspiring, yes.
he is a great human being,
Yes.
philanthropist, and a gentleman to
Yes.
the core. Devendra, who is your hero?
Currently, sir, I follow Shiv Nadar. He's doing excellent
Oh,
job.
yes,
Who?
he's an excellent speaker.
Shiv Nadar.
Shiv
Shiv
Nadir.
Nadar.
Shiv
Ah,
Nadar. He is doing an excellent job. I really
okay.
admire him.
Grish and Rajiv, who are your heroes?
Mine is Amitabh Bachchan, sir. I'm a big fan of
Okay.
him.
Okay, what about Rajiv?
Mine, I would say there are different heroes in different
No,
sections,
no,
but
one
yes,
word answer
in
now. We have only 2 minutes to go. Okay.
you,
You?
Great
you are
answer.
my hero. Right now, you are my hero. At this point of
You know
time.
how to
Yes,
get
yes,
the.
yes, yes, sir.
So thank you very much. You know how to get
Yes,
the
sir.
second chance in the. I'm glad that you made my day. Okay, now, when did you feel you felt that there is a break in your career? I mean, break for good, Ram.
I don't know that I had a break in my career.
I mean, the breakthrough or
A
a kind of a
breakthrough.
breakthrough, or what I want to ask is there is a turning point in your life, turning point in your career.
I think the turning point in my life came. I mean, I guess.
I don't want to ask a marriage or anything.
No, 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 I don't.
Just a
Okay.
career only. No. I know you will say Banu, then she
So
was listening.
in my career, when I came under the influence of Dr. Martin, I think.
That is a break. So where you met a mentor.
Yeah.
I just want to tell that. That's what Rajiv also said. Mentor. Where did you have the turning point in your life, Saurabh? Or you are still waiting for?
I think no. I think it was when I came under the influence of Dr. M.K. Bhan, who was my professor at AIMS.
He was your mentor,
Yeah.
and the time you met, you had the turning point. What about Sobana?
So when I went to train with Dr. Don Castell,
Ah,
he taught me so many things. The first thing he taught me was just be simple. We call it simple studies. Don't get into complicated stuff. And he was a fantastic teacher. So that is what influenced me a lot.
And Devendra, where did you feel that? Or
Well,
waiting for that?
the day I met Professor Samiran Nandi, very forthright, blunt, and very upright person. The day I met him, I
Okay,
thought, well, I
Samiran
am in the
Nandi,
right
I
position.
understand.
Yes.
He has inspired many people. And
Yes.
Girish,
Mine is, sir, my headmaster, who has created means
okay.
creativity
You
in
are
my
a
mind.
school headmaster, Raju.
Yes, yes, sir, yes.
The day I joined MEOT took a turning because I was never sure of which branch I would take. Gastro was in my top 3, but when I landed up in Gastro, that was a turning point.
Okay, now everyone had a turning point and waiting for that. So I think we had a fantastic session, and both are very great teacher, Ram and the Saurabh, and you made us to work very hard to answer the question also, Saurabh, and you are a tough teacher but a very good teacher. And Sobana added the values to as a moderator and my panelist, and all over the world people are watching. And I must thank ACG for giving this opportunity and to organize such a webinar. And Vivek, you have come here now. Who is your hero in life? Vivek?
I'm going to say you.
Okay. And how is you were in India, now you are in USA. What the difference you find among the students doing research, not doing research, or a research point of view?
I think I would like to answer it as a supply and demand scenario. To get into gastroenterology over here is very extremely difficult. So it's kind of
You
the
mean in
residents
USA?
who are
In
in
USA.
USA. So they're forced to do some sort of research. And I was listening to the whole lecture from both professors, and meta-analysis is something that's easier to do when you're not in a place where you can do prospective or retrospective studies. That way you can understand the literature and also get some papers and publications and citations. But the real research is, when you try to do something individually, building up, a retrospective or a prospective database. But that's not easy to do everywhere.
So how easy to get a grant from research?
Grants, when you're a junior, fellow or a faculty just beginning your career, they don't know you. So unless you work with someone senior, have some publications in that area where you're trying to get a grant, it's not an easy task. So I think, if you need to.
You unmute yourself. Okay.
Sorry. The grants, of course, as a early career faculty, it's not easy because they don't know who you are. So unless you have publications in that area where you can demonstrate that you've done significant work, it's not easy to get a grant. So it's always like it's like a hamster on a wheel. You're trying to catch it, but the wheel's spinning so fast that you're not able to keep up. So my personal take is you need to work with someone who's established in the field to understand research methodology and get some papers, and then you begin your career by getting grants.
I think that is very important. And how much the research is respected or valued in USA, and how much it is helpful for the career, where it is mandatory to do the research, or what is it?
I think original research is valued everywhere. In the USA particularly, if you have interest and if you put in the hard work, your visibility is there. Um, Of course, if you're in a big name center like Mayo Clinic or Harvard, it's always easier because they have people who've been doing this for, years and years. And if you want to get a grant from the NIH, it's easier to get it if you're from a big center. So, and once you publish in the field, then you're invited everywhere to, give talks. You become an authority in a particular. I think our field is changing so much that we cannot do everything. We're trying to focus on one particular area and try to get our expertise in that. And eventually, after 20, 30 years, you become a world authority and you're invited everywhere.
You said the field is changing there, here, everywhere, gastroenterology. What is the real in thing there in now in gastroenterology in USA? The real focus on research now, which area?
Um, I mean, it's becoming more interventional, more minimally invasive. So I think interventional EUS, third space, and as we had discussed before, even trying to bring in like image enhanced endoscopy is some of the areas of focus right now.
How much has really influenced, helped, or in a better way, or spoiling in
There's
research in
pros and
the
cons. AI, I think, is going to change our field in 5, 10 years in a big way. But I think we're still in the stages of infancy where we're trying to understand if it's something that's going to impact our lives significantly. And, like how Professor Ramakrishna explained, you have to take what's good from ChatGPT or Copilot, anything. You have to make sure you do your own research and, validate it and substantiate it. But I think in 10 years from now, the field is AI is going to revolutionize every field for that matter.
I think you observed both the lectures very clearly because you are quoting Ramas and other things. Anyhow, I'm glad that you are there, and he is in Dr. Vivek Sanjim. He is in Augusta Medical University, Georgia Medical University. Anyhow, we had a wonderful time. This webinar is a milestone in my the webinar series. The reason is research should be part of all our day-to-day. When you do research in Google, which shop is better for buying orange, for apple, or this fruit, or so many things, Google review, everything. So it has become, but professionally also with all of us, we should catch hold of people like Rama and Saurabh, Sobna, and other teachers, where Philip, everyone, and get mentorship from them. Or when your ideas are bright and you are collecting the data, you get their idea. That is the reason why we have started just inaugurated pages. That is a Pan-India Gastroenterology Research Study Group. I can rope in all the stalwarts in India. If the youngsters are ready with their multicentric study at a small volume or large volume, they will also help us. And Sarup is always there to help us to which design to focus on all the things. So thank you very much for this wonderful webinar. I look forward to the second session on research methodology. Don't miss it. The continuity will be there. I request all the stalwarts also to attend. Thank you very much once again on behalf of ACG for this wonderful. Thank you.
Thank you.
Thank you.
Thank you.
Namaste, Sarji. Thank you.